Yeah.
So we're maintaining, because if it's one of those if it ain't broke, don't fix it
yeah.
type of thing. Is some people feel that may not be a bad patient to do a Cleopatra-like approach, do an HP and palbociclib approach. One could also do induction with T-DXd. Do T-DXd and then switch her over to a maintenance therapy. I think we're going to individualize. I will tell you, I'm dealing with this right now with a patient in practice. And it's not so easy to give up on a treatment that somebody's doing really well on. She's a bone-only patient, and she's got a history of cardiac. And I wasn't sure I was going to be able to get much in the way of a HER2-based therapy. And we happen to have a very talented cardio-oncologist who said, treat, you know what I mean? And so she's done great. Her heart's done super well with it. And her PET's long been negative now. And she's doing great. And she was asking me, when can I go over to some HP, et cetera. But the more we talked about it, and I'm like, are you having any toxicity? And she's really doing very well. I think we may have reduced the dose at this point once or something for some fatigue. But at the end of the day, neither of us has really decided, hey, this would be the right thing to do to switch you.
Yeah.
So we're maintaining, because if it's one of those if it ain't broke, don't fix it
yeah.
type of thing. It's hard to change off of something that's working well, as long as people are doing well on. She's having an excellent quality of life. So I think it's going to be individualized, but there are patients, there's such a heterogeneous disease, and those are some of the variables I think that are going to be just discussions with patients.
Sure.